Welcome, everybody. I'm very pleased that we have Alvin Alvin Teo, sorry, and also Khay Mar Aung from both of whom who are part of the TBCRE and based at the University of Sydney, and were very kind enough to come across today and talk to us about the journal that was recently published within the Lancet group. I'll let them talk to you more about the paper, but to introduce Alvin, Alvin's a research fellow who I've known for several years at the Uni of Sydney. He came across, he's got a background in pharmacy and public health, and he's very interested in epidemiological burden of TB within our region and how we control it. TB burden in Asia Pacific being one of the highest in the world. He's done lots of work around the world in Africa, Asia, Eastern Europe, but his work largely is based in the Western Pacific region at the moment. Khay Mar is a medical doctor and a public health physician from Myanmar, and she's currently in her first year of a PhD at the Uni of Sydney. And her role as part of her PhD, she's doing the SAPPHIRE TB project, and they're doing a population TB-wide screening survey in Cambodia. They're going to talk to us a little bit about that work in Cambodia as well, which I'm very excited to hear about. So over to Alvin and Khay Mar. Thank you.
All right, so good afternoon, everyone. My name is Alvin, and very pleased to share this paper with you today alongside Khay Mar, who will also be discussing results from the Cambodian prevalence survey, and also to reflect some of experience leading the prevalence survey in the last couple of years in Cambodia. So the paper we're presenting today, it is called Screening for Asymptomatic TB Among Adults with Household Exposure to Pulmonary Tuberculosis, a prospective observational cohort study, which was published in November 2025, I think, in Lancet Infectious Disease by Mendelssohn and group in South Africa. And before we start, I'd like to acknowledge the traditional owners of the land we work on today, including the Gadigal people, the Eora Nation, on whose land we're joining, and pay our respects to elders, past, present, and emerging. So this is the outline of our presentation. I will go through the background and methods section of the paper, and Khay Mar will discuss the results from this paper we are presenting today, and also reflect on the experience implementing the Cambodian TB prevalence survey, and also hopefully compare and contrast some of the results from the survey with the paper we are discussing today. And we'll conclude the paper and open the floor for discussion. So I'm just going to looking at my computer. Right, all right. So we know that about 10 million people develop TB globally every year. This number hasn't really changed in the last couple of years. And about 25% of people went undiagnosed or untreated every single year. There are now a couple of systematic reviews, scoping reviews, that reported that more than 50% of TB found in the community, using data from either published literature or prevalence survey, classify people with TB to be asymptomatic, and these are people with no cough, fever, night sweats, or weight loss, or depending on how asymptomatic TB it was defined. Modeling estimates estimated that about 50% of asymptomatic TB cases will never progress to symptomatic TB, while the other 50% remain infectious and risk progression to disease, the symptomatic disease. Asymptomatic TB may also account for a greater share of transmission than symptomatic disease due to longer undetected duration. I think there are several modeling papers that have established the risk of transmission among people who do not report symptoms. All right, so in the WHO guidelines, the screening guideline module 2, WHO reported the sensitivity of TB symptom screening as 70.6%, and the sensitivity of any chest X-ray abnormality as about close to 95%, based on a Cochrane meta-analysis where they derived data from prevalence surveys gated using positive symptom screen or abnormal chest X-ray. So what Mendelssohn and and colleagues did was to review the evidence using data from studies that perform universal sputum testing for TB as part of this paper. And they found that using data from studies that perform universal sputum testing regardless of symptoms or chest X-ray abnormalities, they did a meta-analysis and reported that the sensitivity of TB symptom positive or TB symptom screening was 52%, much lower than the sensitivity reported in WHO guidelines, and the sensitivity of chest X-ray abnormality was 62.4%, far below the threshold for new products. And so this study aimed to determine the diagnostic yield and sensitivity of symptom screening, chest X-ray screening, and universal sputum testing for microbiologically confirmed pulmonary TB among TB-exposed household contacts in South Africa. So this was a prospective observational cohort study, and they recruited household contacts of adult index person with bacteriologically confirmed pulmonary TB, defined as those who slept in the same household or spent more than 4 hours per week of close exposure within the last 6 months with the adult index person. This study was conducted between April 2021 and September 2022. The study was conducted in South Africa and excluded people with psychiatric illnesses, substance dependence, and people in incarceration. So they performed symptom screening, chest X-ray, and universal sputum testing regardless of symptoms and chest X-ray abnormalities. For symptom screening, they collected information on whether the person reported cough or experienced cough, fever, weight loss, fatigue, night sweats, chest pain, cough with blood for any duration. For chest X-ray, any abnormalities indicative of TB disease include cavitation, opacity, bronchiectasis, and chest X-ray was read by a single reader without the use of CAD. For universal sputum testing, they collected sputum sample from all eligible persons and performed expert ultra, liquid culture, and also smear microscopy. For a subset of people with TB and healthy household contacts, they collected blood samples to measure CRP. They also looked at serum samples collected at baseline before TB diagnosis among symptomatic clinic attendees. I understand from the paper that these were samples collected outside of the scope of the study. So they used existing samples and looked at CRP levels in this population. And in total, they measured CRP levels among 600 odd adults self-presented to clinics with presumptive TB, with about close to 200 of them with sputum microbiologically confirmed symptomatic TB, and 408 of them were symptomatic controls with negative sputum culture and expert ultra. So these are the definitions, reference standards, and study outcomes reported in this paper. So people were considered as symptomatic if they reported more than one of these symptoms for any duration, and asymptomatic TB for those who did not report any of the symptoms listed here. For a person to be considered as microbiologically confirmed TB, you must have at least one sputum positive by expert ultra or liquid culture. And in this study, they excluded trace positive results. So the study outcome is to look at diagnostic yield and sensitivity of microbiologically confirmed pulmonary TB in this population. So I'll hand it over to Khay Mar to present the results and also some relevant findings for the recent Cambodia prevalence survey. So over to you, Khay Mar.
Thank you, Alvin. Thanks, everyone. So from the study, they screened around 1,001 household contacts. Out of that, 979 household contacts were enrolled in the study. And finally, study identified 51 microbiologically confirmed pulmonary TB cases, and out of which 9 were symptomatic and 42 were asymptomatic. So these are the characteristics of the study population. The majority, around 65%, were female, and they have around 90% living with HIV and around 90% with past TB history. The median age was 34.8, And asymptomatic of the study population at the time of enrollment is 85.2%. And they have measured around 52.6% current smoker. And the study did really well in collection of the sputum, around 98.3% provided sputum sample for examination. So these are the main findings from the household context. They identify 5.2% of bacteriologically confirmed pulmonary TB, which is more than 6 times higher than the community rate. And out of that 51, 82.4%, 42 out of 51 cases were asymptomatic. And out of 42 cases, only 13 cases, around 31%, were smear positive. And then as a main outcome of the study, they compare the performance of different screening tools. And then symptom screening approach has sensitivity around 70.6%, and they would have missed 42 asymptomatic, around 82% of the cases of bacteriologically confirmed TB. And chest radiograph screening, chest X-ray screening, have sensitivity of around 62%. And the chest X-ray would miss around 19 cases, 38% of all tuberculosis cases. And they also compare the parallel symptom screening together with chest X-ray screening, and the sensitivity increased up to 64%. But however, among asymptomatic participants, the chest X-ray screening has sensitivity around only 56%, and they would miss 18 cases of around 43.9% of people with asymptomatic tuberculosis. And then study highlight the chest X-ray sensitivity around asymptomatic population and symptomatic population. For chest X-ray screening, among asymptomatic cases, they have sensitivity around 56.1 and symptomatic cases 88.9. And they didn't see any chest X-ray abnormality in 18 out of 41, which is 43.9% of asymptomatic cases. So the study said the universal sputum testing detected 18 cases, symptom negative, chest X-ray normal, asymptomatic TB cases, and that increased their G by 54.5%. So based on that, I would like to reflect the recent work that I did in Cambodia National TB Prevalence Survey. This is just to give you the overview of the TB screening algorithm in the prevalence survey. We did parallel symptoms and chest X-ray screening for all participants. So if participant either symptom positive and or chest X-ray positive, they will undergo sputum examination by expert ultra. The team called it a 2 specimen. And if either of the expert ultra positive, including trace score, they will continue to the 2 sputum collection for detection with liquid culture and solid culture. For symptom positive, survey used the prolonged cough, 2 weeks or more as a symptom positive criteria. For chest X-ray abnormality, survey used both human readers and then CAD. Any abnormality, possibly TB, including heat lesion by human readers and or CAD score, we use the cutoff point of 30. They will be identified as chest X-ray presented, chest X-ray positive on screening, and all these cases will undergo expert ultra. And specific to Cambodia survey, if regardless of the expert result, if a human reader identify active TB on chest X-ray, they will undergo culture by MJN solid culture. And these are the findings from the prevalence survey and comparing with the Mendelssohn study. For symptom screening, I didn't use the prevalence survey definition. I used the similar definition from the study. Any TB suggested symptom. A total, we have 34,836 participants. And out of that, around 38.5%, they were positive on symptom. Which means they reported any one of the TB suggested symptom. And out of the study identified 128 cases, survey TB cases. But according to the Mendelssohn study, the number presented by symptom screening is only around 14.8%. And for the prevalence survey, we did the chest X-ray screening, and out of participants that underwent chest X-ray, around 11.2% has a chest X-ray abnormality indicated of TB plus CAD score more than 30. And out of that, we identify 189 cases. And the medicine study, they identify around 137 cases, which is 40.7%. But in prevalence survey, we identify around 11.2% presented on chest X-ray screening. And if we look at the different asymptomatic and symptomatic group, in asymptomatic group, chest X-ray identify around 9.2% presented on chest X-ray screening. And out of that, 67 cases were identified as a radiologically confirmed TB. Because we don't have if they are normal on chest X-ray, we did not further do the testing, so it's 100%. All asymptomatic cases have chest X-ray abnormality. And for symptomatic cases, chest X-ray screening identify around 40.7% presented on TB, and out of that, 122 were radiologically confirmed TB. Only 2 cases have normal chest X-ray in the prevalence survey. And when we analyze by parallel symptom and chest radiograph screening, the survey identified around 12.6% of population positive on screening, and out of that, we have a total 195 survey TB cases. But in Mendelssohn study, if they have parallel symptom and chest X-ray, they identify around 26.4%. So these are the difference between the Cambodia prevalence survey and the Mendelssohn study. And these are some personal reflection. So for sure, definitely the survey design missed TB cases that are asymptomatic with normal chest X-ray. At the time of the survey planning, the technical group recognized this one, but the burden of this group were assumed to be minimal. And then universal student testing require intensive resources like budget, human resource, and laboratory capacity. That's why the survey team decided to go ahead with our current algorithm using chest X-ray and symptom as a gateway. And with the current study finding from the medicine study, the assumption we have on the burden of this group probably might need to reconsider. Maybe this is bigger than we expected. And in Cambodia survey, using the symptom screening, I think around 66% of TB cases identified in Cambodia survey reported at least one TB suggested symptom. But in Mendelssohn study, it's only around 14%. So I think this may be explained by differences in population characteristic and also differences in symptom probing technique. Because in Cambodia prevalence survey, we have different teams. Even at the team level, they have a different positive on symptom screening. So it differs on how we probe and ask the symptom questions. And role of chest X-ray and CAD. In survey, we use both human reader and CAT. The parallel use of chest X-ray with CAT might lead to a higher number of TB cases being identified, where in the study, they only use one reader with the chest X-ray screening. And also, interestingly, in Cambodia prevalence survey, the median CAD score was similar between asymptomatic and symptomatic TB cases. And also nature of asymptomatic TB cases in Cambodia. These are not very as early stage as we initially expected. Many of the asymptomatic cases show significant chest X-ray abnormality. More than 60% show active TB with or without cavity. So which indicate those cases might be like chronic or previously established TB. Also, they were delayed clinical manifestation rather than true early TB cases. And also in survey, we use 2 sputum sample for expert that could have potentially increased the number of TB cases detected. And this is the result from the current medicine study. The CRP was measured in a subset of 25 asymptomatic cases and 7 people with symptomatic pulmonary TB cases and 126 healthy household contacts. they describe the graph they describe for the two separate cohort. One cohort is from the household context, and the another cohort is from the hospital clinic attendees. So 607 symptomatic adults presented to clinic with tuberculosis symptom. They have 199 people with symptomatic pulmonary tuberculosis and 408 symptomatic control without tuberculosis. So the CRP was not able to discriminate between household contact with asymptomatic tuberculosis disease from those with tuberculosis. They have AU's area under the gap of 0.60. And sensitivity for CRP for the diagnosis of asymptomatic TB among household contacts only 48% when they set the specificity at 70%. Yes.
Right. So thanks, Khay Mar. So I will conclude by just highlighting some of the key discussion points from the paper and some key takeaways. So the authors reported that universal sputum testing identified 54.5% more TB cases that combine symptom and chest X-ray screening. And the current approaches we use not only in the paper, but I think a lot of the active case finding interventions are implementing fall far short of the WHO target product profile, which calls for more than or equal to 90% sensitivity. And national prevalence surveys, as what Khay Mar has presented, that skip universal sputum testing and use either both symptom and also chest X-ray screening may substantially underestimate the asymptomatic TB burden or TB burden in general. So the paper, what they did was they extrapolated, in the discussion section, they extrapolated the South Africa National TB Survey, which reported about 852 per 100,000. And if they used the universal sputum testing as an approach to screening in the National Prevalence Survey, the true prevalence could go up to more than 1,300 per 100,000 population. Interestingly, they also discussed the different screening trials that have been implemented so far, and they highlighted a couple of them. So they compared and contrasted two trials, the treat and the scale trial that utilized symptom or chest X-ray approaches, where they failed to reduce TB incidence. I think they were both reported. One was in the PLOS Medicine paper, and the other one was in the PLOS Global Public Health, I think. And both papers reported that they failed to reduce TB incidence after implementing the symptom chest X-ray approaches to community screening, whereas the ACT3 trial in Vietnam conducted between 2013 and 2018 that utilized universal sputum testing using EXPERT. I think it was EXPERT MTB Risk, not EXPERT Ultra. So sorry for the mistake there. And the ACT3 trial reported a reduction of 44% in the intervention site compared to the control site in terms of TB prevalence. So the authors argued that asymptomatic TB left untreated. So these are people who do not have symptoms and also have a normal X-ray, but potentially have TB and left untreated may explain this contrast and the impact at an epidemiological level. So the triage tools validated in symptomatic clinic patients like symptoms, chest X-ray, and CRP, as highlighted by the authors in the WHO guidelines and also the CRP sections of the paper, cannot be widely adopted for community screening among asymptomatic individuals. And they concluded that in the absence of better non-sputum biomarkers, universal sputum testing should be considered for targeted high-risk groups such as household contacts. I'll be very interested to hear from the audience as well in terms of this approach of testing everyone in the general population for TB, and also reflect on some of your experiences implementing such approaches at scale in the community. So these are probably the 5 key takeaways from the paper. That the majority of them are of confirmed TB in household context was asymptomatic, up to 82% in the paper, and therefore symptom-gated screening is inadequate. Chest X-ray screening will miss approximately 44% of asymptomatic TB, and the combined symptom X-ray approach achieved only 64% sensitivity, and this was far below the WHO 90% target. CRP is not a viable community screening tool for asymptomatic TB, unfortunately, and universal sputum testing using EXPERT Ultra with or without culture is currently the only approach with adequate sensitivity for high-risk groups such as household contacts. And lastly, National Prevalence Survey for TB, omitting universal testing, are likely to substantially underestimate the true global burden of asymptomatic TB. I see the questions streaming in, so I'll just stop there and open the floor for questions. Thank you.
Thank you so much, Alvin and Khay Mar. Firstly, I'd like to congratulate you on very clear slides. I had read the paper. There were lots of numbers and lots of proportions. And so it was very nice to have it distilled into a seamless fashion. The first question, I think, is from Beth. Beth has said, and reflects also something that I was thinking, she was surprised that more than 98% of asymptomatic people in Cambodia were able to produce, oh, sorry, I think, Beth, you might be referring to the paper. No, not Cambodia. In the paper, were able to produce sputum samples. That's something I was also very surprised about. What are your thoughts on that, Khay Mar and Alvin, or anyone else in the audience?
Oh, I can start. In fact, we were just discussing about this just before the presentation, and we thought, oh, maybe they would have reported the more details about sputum quality and whether there were any indeterminate or invalid results because of poor sputum quality. The paper, we looked through the supplementary materials. It was not reported, so we're not sure whether what was the quality of the sputum sample that they have collected. And I reckon that they tested all samples regardless of the quality using Expert Ultra. So 98% is a lot higher than what we expected. I think in an ACT trial, I'm not sure if anyone who actually implemented ACT trial is in this call, but I recall that in an ACT trial, they managed to collect, or rather about more than 80% of the people in the community was able to give a sample regardless of quality. But 98% is a much higher than what ACT experienced. So we are not able to conclude whether sputum quality played a role here or not because it was not reported in the paper.
One thing I think I'll say is that, and perhaps I'd like to have Phil's opinion on this, is the role of even just saliva. I'm not sure how important sputum quality necessarily is. I think in a tertiary care setting in Australia, of course, we make sure that we do look at sputum quality and assessments, and some of that is really about what we call diagnostic stewardship. We don't want to do excessive tests because it's costly. But of course, we are looking now at tongue swabs as a means of, as part of diagnostic algorithms to see if that is a useful tool. And Phil is actually implementing a tongue swab study, so maybe he'd like to chip in at this stage.
Thanks. Yeah, so a few reflections. I think the quality of sputum does make a difference in terms of improving pickup. And clearly in the studies that have looked at, taking 3 samples, looking at the different quality of the sputum, you get a lower pickup if you have saliva. Having said that, not all saliva is negative. When we looked in Uzbekistan, a setting that had very high rates of TB, drug-resistant TB, we found that 9% of the TB that was being diagnosed was positive on a saliva sample. So the lab had a policy there not to reject. They suggested try and get a better sample, but still process the saliva sample. I think with the tongue swabs, we're seeing very interesting data. Again, you're more likely to pick up a positive tongue swab when they have high mycobacterial load, and the lower the mycobacterial loads on sputum, then the less likely or the lower the sensitivity on the tongue swabs. So I think every test is going to have some problems. But maybe to throw back, I guess in the paper they did report around the asymptomatics and how many of them had HIV, which is what would be one consideration for a normal chest X-ray. Was there a breakdown of sort of other risk factors other than sort of HIV and smoking? Did they look at diabetes and and other factors? And the second question, if I can jump in as chair, what lab quality aspects did they look at? There was an interesting paper presented at the Union Conference looking at an analysis of a clinical trial, which is obviously running at the highest standards, and yet they had false positives and cross-contamination on culture occurring at busy workload times in Southern Africa, and across sites outside of South Africa as well as in South Africa. So I just wonder, did they repeat test people who were positive to confirm they were in fact TB and not false positives or anything along those sort of aspects?
Thanks, Phil. So I think in terms of the lab infrastructure, they did not report in detail the lab conditions in the project at the sites where the project was implemented. I don't think they repeated any of the tests. They collected one sputum sample for expert and one for culture. I think that was it. So they did not do a they only collected spontaneously expectorated sputum and only one sample for expert and culture. So they did not repeat any of the sputum tests on either expert or culture. And yeah, so they did not report the lab conditions in these project sites.
I'll also come.
Yeah, sorry.
Oh, sorry. Go on. I was just going to very quickly say, Alvin, but they also didn't comment on whether those people who were diagnosed with TB based on their algorithm went on to get treatment. And we don't know whether at the clinical end of things, those people may have had repeat testing before they were started on treatment to confirm that they actually did, as opposed to in the context of a research study. So it's possible that could have happened. This is just
Correct.
Yeah.
That's right. That's a really good point. And in terms of HIV, maybe just before I talk about HIV, I don't think they looked at they did any sensitivity analysis or subgroup analysis by other risk factors like smoking or diabetes. In terms of HIV, I'm looking at it's not reported in the main paper, but it's reported in the supplementary material. So they did a sensitivity analysis comparing the diagnostic performance among people living with HIV and those without HIV, and they did not observe any difference in the overall TB prevalence between participants living with HIV and those without HIV. So they reported that TB cases among people living with HIV were more likely to have abnormal chest X-ray than those without HIV. But the confidence intervals overlapped due to small subgroup sizes. Symptoms and chest X-ray screening sensitivity estimates were just slightly higher among people living with HIV, but again, are limited by the sample size. And I also saw, it's actually related to another comment in the chat box by Andy about prior TB. So they did a similar sensitivity analysis reported in the supplementary material for those who reported a previous TB episode within the past 10 years. And in short, they didn't find that they found that the symptom and X-ray screening sensitivity were relatively unchanged, with a slight reduction in TB prevalence and proportion of asymptomatic TB if they exclude those with prior TB. So in short, they didn't see a major change in the sensitivity of symptom and X-ray screening, excluding people with prior TB. Response to Gail, it was actually 52% people who reported the current scar. Yeah, that's right. Which is surprising because so many people smoked, but when they ask about symptoms, 82% of them reported no symptoms. So it is quite interesting when it comes to symptoms reporting and how subjective it can be. It depends on who's asking the question, where it was asked, and where it was asked as well.
So I think that's case in point about what the utility is of symptoms as part of a screening algorithm. There's a lot of not only is it subjective, There's also lots of limitations in people, even if they are symptomatic and know they are symptomatic, wanting to declare that because often they feel, especially depending on the health literacy, that there are repercussions to saying, why didn't you seek healthcare earlier if you knew you had a cough for the last 6 months, etc. And we see this in every setting. So coming back to the point that was made about detecting between non-viable DNA versus true disease, one of the other things is Alvin and Khay Mar, I think they excluded anyone who had trace results. And also amongst those who were smear negative and only MTB PCR positive, they only had 2 people who had prior TB, who they included as currently having TB. So to me, my assessment was that this was fairly robust in terms of their diagnosis of asymptomatic TB from the community. But yeah, I was also intrigued by the fact that they only utilized a single reader analysis of their chest X-ray, and some of that might have just been logistic issues with the research study not having enough funding to get 2 reader assessments. But it was curious that they didn't utilize CAD as you guys did in Cambodia.
And I think the discussion section, I'm just looking at the paper right now. I think their argument for not using CAD was that in the South African TB prevalence survey, CAD detection accuracy was significantly lower in asymptomatic versus symptomatic individuals. So that was their rationale for, or argument for, not using CAD in this study and use fake human reader instead. But yeah.
Thanks.
But so we're not sure whether that explain why the sensitivity for X-ray was much lower. Could it be the other way around? I'm not sure.
I might jump in there. There was a question also from Tafi on costing data, but Tafi, you had a second part to your question. I wondered if you wanted to add anything, and also from the experience in island-wide screening, has this paper or these thoughts influenced your practice in the protocols there?
Thanks, Philip, and thanks, Alvin and Khay. So I think my question is probably speaking to the same issue around symptoms, and specifically looking at the data on those that had no symptoms, but also had a normal chest X-ray, but because they had sputum, then sputum picked TB. But I think these questions around quality were also for discussion. In SWIP in Papua New Guinea, we're just looking at the data now, and we picked up that subset of individuals that reported no symptoms and had normal chest X-ray, as in card less than 40. That's the threshold that we're using. And we are trying to take a look at this, subgroup to actually find out what are the actual characteristics, or whether they were just children, because we were not doing universal sputum collection for everyone. And that's why I was tying it in with costing to think about if we are to consider which one is the best approach, clearly based on those sensitivities. It's more like if we do sputum on everyone, then we are okay. We don't necessarily have to do a chest X-ray. But at the same time, if we're doing ultra gene expert testing, what cost are we looking at there? So that's why I was asking if there was any costing data as well.
Thanks, Tafi. Sorry to miss the question. Yeah, costing data was not reported in the paper. I'm not sure whether they will publish that as a separate paper, like a cost effectiveness analysis paper. And if so, I'll be interested to look at the results as well.
One thing that I will mention that I thought was really interesting from the paper, and I also really want to get the opportunity to discuss your results, Alvin and Khay Mar, from the Cambodia prevalence survey, was just the female preponderance of asymptomatic disease. And why I think that's really interesting is that in many, many epidemiological studies of symptomatic TB, and usual screening diagnostic algorithms that are used. It's the opposite. We tend to find about, just slightly more males than females diagnosed. And I wondered whether, like many things in medicine, females present differently. And this is perhaps, there might be biological reasons, there might be sociocultural reasons for this, but whether the presentation of asymptomatic TB may be real, and particularly more preponderant in females, and whether anyone in the group had any reflections on this.
Yeah, that's really interesting. I just wanted to add, and not to answer your question, Gail. Just wanted to add, I think in Logan's review in Lancet ID, looking at asymptomatic TB and the different and the impact of different definitions and different cutoff to the prevalence of asymptomatic TB was published in Lancet ID last year. I think they also found that a lot more females reported to have asymptomatic TB compared to men. I may be wrong, but I don't think they discussed the potential reasons behind that. So that could be really interesting as well. Yeah, be very happy to hear if any other people on this call have any insights into this particular topic.
Katie has just said that symptom screening isn't well correlated with anything useful. Katie, you want to comment on that? And do you have any thoughts on how females present with TB as an epidemiologist?
Oh, can you hear me okay?
Yes.
Yeah. Oh, good. Sorry. I think it's I think the issue of females having asymptomatic TB in prevalence surveys, it's interesting. I know that Catherine Horton, I think, published something a while ago demonstrating that the male to female ratio in prevalence surveys differs to the male to female ratio in notification information, and suggested that males, and this inconsistency reflected perhaps that males weren't seeking healthcare and weren't presenting as much as females, but it could also reflect, I think, the fact that the females with TB weren't being picked up in the prevalence surveys as much, I think. So I think that's probably relevant to that point. And sorry, just regarding the symptom screening, I think people have already reflected the arguments I made in the paper in CID about asymptomatic TB, which is symptoms screening in surveys is variable. You can use different thresholds, and whatever the threshold, it doesn't really correlate with anything useful in terms of, unfortunately, people tend to correlate people with asymptomatic TB as having less severe disease and being in an early stage and things, but I don't necessarily think, that's not a correlation that's supported with any evidence, I don't think, and so I think, although there's a lot of discussion currently about symptomatic and asymptomatic TB, I think it's just sort of generating more confusion than anything, possibly.
I do think that the discussion is useful, only because I think we need to change what we do. I think we need to stop counting on symptoms so much, perhaps. And I will just point out, to what Alvin and Khay Mar found was that, even amongst people with asymptomatic TB, they actually had quite heavy burden disease, right? They had cavities. I think that's what you mentioned, Khay Mar.
Yes.
I don't want to lose the opportunity because we've got a couple of other questions. I'll hand over to Phil.
Thanks. So just picking up on Noel, thanks very much. You've made a couple of great points in the chat. Firstly, around the household definition. So obviously in different countries, exactly who is spending time in the household and what's considered the household. And I know in South Africa in some studies they've talked about sharing a kitchen rather than sleeping in the same room necessarily, and broadened a definition. So I think really good points to there. I couldn't see anything in the paper, but maybe you can comment on that in a moment. But Alvin, the other point I think is just the workload. So we can talk about what's the ideal for a prevalence survey, and then we need to think about what's the ideal screening approach for programs and how it can be implemented well, and whether your ideal algorithm actually is implementable at scale. The relapse rates, reactivation also seem a bit of a concern. Noel, I wasn't sure if you had an extra question in there. If so, just pop your hand up and we'll ask you to voice that. But great points.
Yeah, that will do. Thank you.
Thanks so much. And maybe, Mike, I've got a question for Khay Mar. With this paper, do you think we need to change the methodology for prevalence surveys? Is firstly, sorry, unfair questions. Don't feel like you have to answer it, but you've probably thought about it more than most people on this call for sure. And the second question, we're talking here about asymptomatic TB with a definition of proven by the methodologies that are used, i.e. sputum culture, sputum gene expert. But we know in clinical practice, there are people who are negative on all of your sputum tests. And when you do a bronchoscopy, they're positive. And there are some people when you do a bronchoscopy and they've got a big cavity that are still negative. And then when we, treat them, they get better and we presume they're TB. So in the prevalence surveys, we don't tend to include just clinically diagnosed TB on an X-ray changes and symptoms, but negative sputum. Should we be doing that as well? Because that would be another level of underestimate. So where do we draw the line with what is TB?
Well, it is difficult question to answer, but I definitely think for the prevalence survey, we should consider having another study group subgroup to take the sputum regardless of symptoms or chest X-ray result, so that we can know and maybe extrapolate the actual burden. Now we don't have, like for Cambodia survey, we don't have any data on those who are chest X-ray normal and symptom negative. Yeah, I think based on my personal reflection, I think we should change. but it's also quite resource intensive. Yeah. And another thing about clinical data. Yes, in the prevalence survey, we did not count those cases because the survey definition, because of based on the WHO recommended algorithm. But yeah, I think we also should consider those cases as well. I'm not sure how Chris was also there. Yeah.
Thanks so much. I think there's a related question from Andy on, is chest X-ray, if it's so poor sensitivity, should we just do away with it? Andy, I don't know if you wanted to add any comments to that or add on the reflections around what you think we should do given the challenges.
It's a little bit tongue-in-cheek in a way. I don't know if you can hear me. Yes. I guess just thinking about doing tests that are really poor in terms of sensitivity or specificity and whether it adds anything to the algorithm around prevalence studies, given these findings now. It does add to the cost and depending on the setting, I guess, and logistics. So if it's such a poor discriminator in terms of detecting asymptomatic TB, maybe we should think about whether it's necessary and cost effective in this sort of setting.
That's right. Right. I just wanted to reflect on the chest X-ray issues as well. I think it goes beyond sensitivity because with chest X-ray, even with the ultra portable chest X-ray, it is almost impossible to set it up at each house. And as we move along each house and go door to door, it's impossible to set up an X-ray at every doorstep. And so for X-ray, to implement X-ray at scale, based on what we have experienced and what I know, the most feasible way is still to have an event site and expect people to come voluntarily to be screened. And that is actually a major issue as well, because everyone has competing priorities. And how do we screen as many people as possible using this particular approach? And this is where we strike a balance between using a more expensive, more sensitive test versus coverage. Because and cheaper or cost against coverage. With door-to-door approach, collecting sputum sample, I think with the ACT experience, the coverage is great because we can go door-to-door and collect sputum sample on the spot and bring the samples back to the lab for testing. Whereas X-ray, you go and knock on people's door and be like, please come and join us at this event on this particular day. And the turnout has been quite discouraging. I think in the Act 5 prevalence survey, the preliminary data, that if without a mop-up or really an active approach to go knock on people's door, put people on the back of a motorbike and bring them to the event, the voluntary participation rate is only about 30% in selected areas. In Cambodia, we're using the same approach because of cost, and despite trying different ways to sensitize the community and working with different stakeholders at the local level, we're only looking at a participation rate of 55%. So it's much lower than a universal door-to-door approach. And by screening only 50% of the community, what is the impact of disease prevalence, and how do we balance the issue between cost and coverage is something that is something that we have to figure out as well.
What I'd like to propose is, if there was and this comes back to Taffy's earlier point, is, doing a cost effectiveness analysis where the outcomes can be yield, so diagnostic yield of your algorithm of testing, but you do away with symptoms, you do away with chest X-ray, because I tend to agree with Andy. There's definitely a role for chest X-rays in TB diagnostic and TB treatment and care, but does it have to occur at the diagnostic screening level, population screening level? Is I'm not sure. I think all this data is suggesting that perhaps what we could do is begin with microbiological sample testing, and looking at the cost effectiveness of this. And Alvin has laid out a proposal of how that occur. We go out into a community, just collect sputums, and I've even heard at the union presentations where we have pooled sputum. So you go out into a particular household, you collect everyone's sputum, you put it into a single jar and you test that, and that can really reduce the cost effectiveness. If everyone's sputum is negative from that one sample, you can exclude that household, rightly or wrongly, and you do that in an entire population, and then following on from that, you do your chest X-ray. And the utility of chest X-rays is there, particularly in assessing how much burden disease someone has, and that can come back to how long they perhaps have had TB for and how much local transmission, therefore, there might be in the community. I'm just conscious of the time. If we have any other burning questions, please feel free to put your hand up and ask them. There were a couple of announcements I wanted to make, but I wanted to, before we did that, just congratulate Alvin and Khay Mar on the huge Cambodian population survey, prevalence survey that you've conducted, or that your team has conducted. It's incredible work, and to have the yield and the diagnosis that you have had is outstanding. I also wanted to say what a huge burden of disease that's been uncovered. And there would have been a lot of lives saved as a consequence of that. So well done to the team there. And may we continue to do good work in this space. I'll just give anyone an opportunity quickly to comment. We've got 2 minutes to go before we do have to close the session. Okay.
I might just make one
Yep.
small comment, if
Thank
that's okay, because I've noticed someone from one of the potential funding organizations online. So just to make the comment, but I won't point out who it is, that look, we are still needing evidence around what is the best way to screen in communities and what's the best approach for prevalence. And the prevalence data we have on countries is a good guide, but comes with wide confidence intervals. But I think we would still conclude that screening in communities and funding that is better than not doing screening, even if we don't have yet the evidence for the optimal approach. And there is emerging evidence around how we can do it better, and it does need to be context adapted. and the two people who've presented today are probably two of the people who have a lot of experience on how to improve what we're doing. Back to you, Gail.
Yeah, I'll second that and just say not only do we need funding for the work that we need to do, we need also individual funding so that our careers can continue, which, otherwise we lose valuable people in TB science. So thank you everyone for attending today. This was a fascinating discussion. I'd like to thank Alvin and Khay Mar for their wonderful presentation, big effort in putting this together. Our next session will be with Dr. Beth Morgan, who's online. Thank you, Beth, for volunteering to present. We will let you know what the paper will be. It will be probably on the 19th of May, but we will keep you posted by the various communication channels. If you look in the meeting chat right up the top, there is a link for where we record these sessions and then upload them to the ACTnet Journal Club website. So if you want to go back to something, you always can. Please spread the word about attendance and also looking at those Journal Club videos. And then finally, we like to collect feedback to make sure that we continue to improve this service, really. So please feel free to provide any feedback, good and bad, to us. Thank you.